In this video, we're going to talk about second degree block. Particularly, we're going to talk about our type 1 block or our Mobitz type 1 block. And we know that's going to be a AV block. So I have an example of a second degree block type 1 here. And the big thing you have to remember about a second degree type 1 block is that we have a lengthening PR interval. So if you're going through your steps, we're going to want to know things like rate and rhythm. And there are a couple of things that are important here. One is that your rhythm will be irregular. It could be irregularly irregular. It could be simply irregular with a pattern to it, but we know it's going to be irregular. So we have an irregular rhythm. We can see that because our QRS complexes have big gaps in them. So it's not regular. This is typically regularly irregular. So we see blocks of four that have fairly normal spacing and then a big block. So it's predictable. So irregular, but it's predictably irregular. We have to then look at, do we have P waves? And we do. So we can see that we have P waves through pretty much the entirety of the strip here. So I'll use purple to kind of highlight some of the notable P waves here. So we have a P wave here. We also want to be mindful of the fact of a P wave here with no QRS complex to it. So do we have P waves? Yes, we do. The other thing that we want to think about is, do we have a PR interval? And we do have a PR interval, and that's where things start to identify themselves here is we would initially be looking at the PR interval for length. So we want to make sure it's no bigger than 5 to 6 small boxes to identify a type 1 block. So we look here and we see that short, not type 1 block, but we look here and it starts to get longer versus here that's longer and longer and longer. So we do have a PR interval, but that PR interval is progressively getting longer each time we're looking at it. So we have P waves and we have a lengthening PR interval. And that's one of the key giveaways here is that our PR interval is getting longer with each beat. And that would be the key thing to remember is that nothing else really causes that. If we're looking at lengthening PR interval, we're talking about a really specific pathology that's impacting the AV node and particular channels in the AV node. But if we're going to continue through our process, we can also look and see, do we have a QRS complex? And we do. So when we look at QRS, yes, we have them, and they are narrow, which tells us that they're being generated from above the ventricles. But the other piece is there a QRS following every P wave? So do we have full conformity between our P waves and QRS complexes? And the answer there would be no. We know that we have a few P waves here that have no QRS following them. So QRS, yes. After every P wave, no. And what that is telling us is that we have drop beats. And this is pretty much where we can make our decision about what is happening, is when we have an irregular rhythm that has P waves but a lengthening PR interval, and we are dropping a beat, that is almost always going to be a second degree type 2 block. So we can kind of, again, outline what those things are. So what is relevant here is that we have an irregular rhythm. So we want to know that we have an irregular rhythm. We have a lengthening PR interval, and that lengthening PR interval is followed by a drop beat. And those are the keys to a second degree type 1 block. Irregular rhythm, lengthening PR intervals. We have P waves and we have QRS complexes, but the PR interval is getting longer before we drop a beat. So again, we can see that we have a drop beat here, and we are missing a QRS complex that goes along with that. So where we would typically have a QRS complex, there is none. So we're missing a QRS complex right here. So lengthening PR interval, a P wave without a QRS complex, which indicates a drop beat. So we know that the PR interval is related to the AV node. Thinking about what is generating a P wave, we know that what is generating a P wave is the SA node firing. That impulse is heading to the AV node, and the AV node has an important job. It's meant to delay conduction to the ventricles so that we can get atrial emptying into the ventricle before the ventricle fires. So the AV node fires a little bit differently in order to provide this PR interval so that it can perform its essential function. And in order to appreciate how this delay starts to get lengthened to the point where we drop a beat, we have to appreciate what is happening in the action potential in the AV node. So what we'll draw in here is the AV nodal action potential, and we'll use -60 as our kind of benchmark here. So this is going to be a pacemaker potential. So we know that this is a pacemaker potential, and what that means is that the ion channels used are slightly different than elsewhere in the heart. So we have automaticity, which means that we're using our IF or our funny our sodium channels to allow for automaticity. So we have a sodium channel that is allowing for depolarization to the point where we then stimulate a calcium channel, which is going to cause full depolarization. And then we head back into potassium, which is going to cause repolarization. And this will continue as we have automaticity. So a couple things to remember here is that the automaticity is generated by the IF sodium channels. So that is what will allow us to essentially strike enough action potential that we'll start to see depolarization of the calcium channels. What's interesting about our calcium channels is they are not necessarily all or nothing. So they actually start to depolarize somewhere in here. So once we start activating them, they start to depolarize and they will start to fire in order to have our full depolarization. What we're looking at here for depolarization is actually calcium channels. So this is an L-type calcium channel is providing depolarization to this pacemaker. So the AV node is using this L-type calcium channel in order of depolarization. And then finally, what we see is repolarization through the potassium channels. So we have a voltage gated potassium channel that is opening in order to allow for repolarization. So that's nothing new. So again, the important piece here is that we're seeing IF sodium channels that are allowing for automaticity. So basically, as soon as we hit this -60, they open and they are allowing for sodium to start rushing in. Sodium, as it's entering, is going to start stimulating our L-type calcium channels that function through here. So they're opening, and eventually we get to the point where we have an action potential. So calcium is flowing in through here, and we hit our peak potential where then potassium channels open, and we're going to have potassium efflux, and we're going to have repolarization. What we also have to appreciate here is that when we're looking at essentially getting back to our normal action potential, so as we have repolarization or stabilization of the membrane, a couple things are happening. We know that our sodium potassium pump is working in order to pump sodium potassium back to where it's supposed to be. We also have our NCX channel, which is our sodium calcium exchanger. And we do also have some intracellular pumps, for example, our circle pump that is going to be pumping calcium into the sarcoplasmic reticulum. So for all of this to function appropriately, what we need to have is after we've had depolarization, we need potassium channels open to have repolarization, and we need our pumps to work to get the ions back to the right places in order to have an action potential again. And the issue that exists when we're looking at a second degree type 1 block is that these calcium channels are not functioning appropriately. And what's interesting about the L-type calcium channel is that it fatigues in a decremental manner. So it will progressively fatigue rather than simply not hitting an all or nothing response. So what's different about this compared to, say, a myocardial action potential or the action potential in the Purkinje fibers is that calcium channels are decremental, they are not all or nothing. So it can slowly fatigue rather than suddenly hitting a point where we can't have an all or nothing response and it won't function. We can see decremental fatigue of the calcium channel, which can lead to some of the issues that we see in a second degree type 1 block. So if we take a look at our AV node, we can draw our AV node in here. We've got our big AV node, and what happens here is something is preventing adequate function of the calcium channels. The most common thing that is going to impair function of these calcium channels is ischemia, which is going to prevent our sodium potassium pump from working effectively. It's going to prevent our sodium and calcium exchanger from functioning appropriately. So something basically is slowing down the function of these calcium channels. And what we're going to do is we're going to draw that in dark blue here. As I highlight our calcium channels, what we start to see is dysfunction in this area. So these channels are not going to function as appropriately as they're supposed to. So we start to see delayed function here, some dysfunction. So this is going to be representative of dysfunction. And again, what we have to remember is that this is going to be decremental. What that means is that we have progressive fatigue. So what normally happens is an impulse will come down from the SA node, will travel through the AV node, which will slow the impulse down a bit in order to create our PR interval prior to exiting and heading towards the ventricles. We will have normal refractory. So what will happen is you will have a normal refractory period through the AV node, and as the next impulse comes and is ready to travel through, this refractory has dissipated, and the next impulse can come and travel down the V node and stimulate the ventricles just like the other one did. Now, what's happening when we have a second degree type 1 block is that something is preventing these calcium channels from doing their job effectively. And what that means is that they're likely going to stay in refractory longer. And we know that that refractory period is decremental or it will prolong or progressively fatigue over time. So what's happening in second degree type 1 block is these channels are not necessarily ready to fire because they're refractory. If they accept an impulse, that refractory will just get longer and longer and longer because it progressively fatigues. So we have an issue. We have ischemia or vagal tone or something that is preventing these calcium channels from working effectively. It's leading to more an increase in refractory period for these calcium channels, and that will get progressively worse or will have continuous fatigue as this moves on. So what happens in this case is we have an impulse that comes down from the SA node and will work its way through the AV node, then travel out to the ventricles. And that will create a refractory period, like we talked about previously. So we see a refractory period. The problem is, because we have ischemia or increased vagal tone or medication that's preventing calcium from getting back to the right place fast enough, what happens is we have prolongation, or that refractory period is prolonged. So before it dissipates, what we end up seeing is another impulse traveling down from the SA node. It can travel through this tissue. it will take longer because some of that tissue is in refractory. So I get a longer impulse. So the impulse takes much longer to travel down, and it will go to the ventricle. So as a result, we start to see lengthening of our PR or PR interval. This impulse will also create refractory. So the darker this gets, the more refractory we're in. That impulse will dissipate, but now we do have a long refractory period or a longer refractory period or more tissue in refractory because it is decremental. I think about what happens next. So now we have our next impulse. We've had impulse one, we've had impulse two, impulse three travels down from the SA node to the AV node. It takes a really long time to get through this tissue because so much of it is in refractory. The interval gets even longer, and then we stimulate the ventricles. So this is impulse three. We can guess what's going to happen here is now we have even more tissue in refractory. As that other impulse comes through, we're stimulating more of those cells and creating more refractory tissue in a decremental way. And this process will progress until the point where we have an impulse coming down, as we see here. As we see here, we have an impulse coming down, and so much tissue is in refractory, we can't have an impulse generate. So nothing flows through that refractory tissue. Time, so this gap in time that we see here is essentially a reset and gives the AV node time to exit refractory, and the same thing happens again. So our first impulse comes down, we travel through the AV node, stimulate the ventricles, and we get this progressive refractory period starting all over again. So the key here is that in a dysfunctional AV node, we have something that's preventing calcium from doing its job normally. Typically, this is going to be ischemia that's impacting the sodium potassium pump, it's impacting the sodium calcium exchanger, and our calcium channels can't work normally. As a result, it's harder for them to be stimulated, and it takes longer for them to come out of refractory. So we have a longer refractory period. As we have sequential stimulation, that refractory is decremental, so it gets longer and then longer and then longer until we hit a beat, or we have a beat coming down from the or SA node that cannot stimulate, and we drop a beat. So that is why we see progressive lengthening of the PR interval in a second degree type 1 block, is that something is impairing normal calcium function or normal calcium flow across the membrane in the AV node. Our AV node requires L-type calcium channels in order to function properly. So usually we're typically using an L-type calcium channel in order to allow for stimulation or conduction of an impulse through the AV node. We get decremental fatigue, or we see progressive fatigue. Every time an impulse comes through, it's harder to stimulate these cells because more and more of them are in refractory, and it's taking a long time to get out of that refractory period until eventually we have so much tissue in refractory that we can't have an impulse. So let's put that into a flow chart. So in order to get a second degree type 1 block, typically we have something that's going to decrease calcium. So let's put this in a flow chart. Something is preventing the normal flow of calcium in the AV node when we have a second degree type 1 block. Whether that is structural damage, ischemia, inflammation, it doesn't really matter. That reduction in flow of calcium through those calcium channels, or those L-type calcium channels, is prolonging depolarization. It's harder for that impulse to make it through the AV node. But what's interesting about that is that prolonged depolarization also prolongs refractory. And this is a cyclic process. So the longer our refractory period is, the more prolonged depolarization is. And these are going to cycle back and forth. Every impulse will lead to a longer refractory period. Every longer refractory period is going to lead to longer or prolonged depolarization. This is why we see the lengthening PR interval until eventually the terminal endpoint is this, is that refractory is so long that we drop a beat. So we get to a point where we have this really long refractory period. We have a huge reduction in calcium ions or channels available. And what's going to happen is we drop a beat, or the consequence is this dropped beat. Now, the benefit of the drop beat is that we have reset. So the drop beat allows for rest of the tissue, have that tissue exit refractory, and we start at the top again, and we start to see the same thing happening. So it's that rest period that gives us the reinitiation of this process. Now, the problem is that a second degree type 1 block is not usually that detrimental. We can see some bradycardia. Usually we're just going to monitor it until it gets to a point where the bradycardia is severe or is leading to symptoms. But it's a little bit ominous because what it can tell us is if we don't fix the problem. So if there's an issue leading to progressive ischemia or decremental damage to the AV node, is that if that continues, so if that issue, whatever it is, continues and progresses further down, if it gets low enough in the AV node, it can actually begin to block exit, and that's how we could end up to a second degree type 2 block from a second degree type 1 block. So finally, we can take a look at some of the things that could cause someone to have a second degree type 1 block. The number one is going to be ischemia or structural disease. Often we're looking at things like progressive ischemia, so someone who maybe has had ACS or acute coronary syndromes for a long period of time, which has led to damage to their conduction system, or the person's having a big heart attack right now. We can also see it with things like increased vagal tone. So athletes, people who are sleeping, individuals who are experiencing carotid massage or something's irritating the carotid bodies. Medications, things like beta blockers, calcium channel blockers. Calcium channel blockers would be a big one because they are specifically blocking those L-type calcium channels. We can see it in electrolyte imbalance, so things like hyper or hypokalemia, hypocalcemia, hypermagnesia, and then a litany of other causes. So things like Lyme disease, myocarditis, valve disease, post-cardiac surgery, increased ICP. All of those types of things can also cause more transient second degree type 1 blocks. The big one we want to think about is ischemia, and that will be one of the primary causes.